Hello, I'm Brenda King, Nurse Consultant in Tissue Viability, and I'm going to cover two modules talking about stalled wounds. The first module will talk about factors which affect healing at a molecular level. When is the wound considered stalled? The definition of a stalled wound tends to overlap with what we know of chronic wounds. We consider a wound to be chronic when it's failed to progress through the healing stages within a specified time frame. It's generally considered a wound that fails to progress for between 4 and 6 weeks is actually classed as chronic. When wound healing stalls, this tends to be in the inflammatory phase of the healing process. And there are a number of factors why the wound may well stall. Some of these are patient-related, and nutrition plays a very important part. Protein, carbohydrate, fatty acids and trace elements are absolutely essential for wound healing to take place. In some patients there may be obesity which decreases tissue perfusion. There could also be underlying comorbidities which include diabetes, autoimmune disorders, arterial problems and cancers. There may be psychosocial issues, there may be stress-related factors around the wound, leading to a lack of sleep, or it may be pain that's affecting the sleep pattern. Patients may well be non-concordant with the recommended treatment. It may be the medications used to treat comorbidities, such as steroids, chemotherapy or radiotherapy. However, it's essential that the wound is assessed by a suitably trained practitioner, so any wound-related issues can be identified early to prevent the wound from stalling. It is essential that any increase in bacterial load and possible infection is identified and treated promptly. It could be there's a high level of exudate which leads to peri-wound maceration. The wound may well be dry due to low levels of exudate and the wound bed become desiccated. In the cases of pressure injury, there may be unrelieved pressure over the wound bed. So let's consider normal wound healing process. Wound healing tends to be divided into 3 phases: inflammatory phase, proliferative phase and the maturation phase. The inflammatory phase starts immediately there is any injury to the skin surface and starts with constriction of damaged blood vessels and hemostasis to stop bleeding. Platelets release factors that attract other important cells to the injury, in particular the neutrophils, a short-lived inflammatory cell that migrates to the wound to begin and break down dead tissue and transport debris away from the wound. Monocytes are also attracted, which differentiate into macrophages. The macrophages fight bacteria and break down necrotic debris and activate the fibroblast. At the end of the inflammatory phase, the macrophage activate programmed cell death in the neutrophil. This controls the inflammation and heralds the start of the proliferative phase. In the proliferative phase, there are signals which encourage epithelial cells or keratinocytes, collagen formation, and the myofibroblasts into the wound, which all bring about wound repair. Once the wound is healed, there is a period of maturation. The fibroblasts leave the wound and collagen is remodeled into a more organised matrix. Tensile strength increases for anything up to 1 year following the injury. While healed wounds never regain the full strength of uninjured skin, they can regain up to 70 or 80% of its original strength. So if we consider that wound healing stalls often in the inflammatory stage, then it's quite important that we consider a timely resolution of the inflammation to avoid the wound becoming chronic. The inflammatory response results in the build-up of a large number of neutrophils or short-lived inflammatory cells. Clearance of these dead cells by the macrophage triggers the proliferative phase. On phagocytosis of the neutrophil, the macrophage changes from an inflammatory phenotype M1 to an anti-inflammatory phenotype M2, and then secretes signals that will resolve the inflammatory response. These signals include anti-inflammatory cytokines and growth factors which tell other types of cells in the wound to progress into proliferative and repair phases and start performing the tasks associated with them. Therefore, the macrophage plays a very important central role in the management and coordination of the healing process. So let's consider why wound healing may stall in the inflammatory phase. And we'll look at the elderly population and we'll look at patients with diabetes. When we consider increasing age, the macrophage displays age-related alterations in its function. There's reduced fibroblast and epithelial cell proliferation, and a reduced number in the cells responding to growth factors, cytokines, and angiogenic stimulation. If there's any arterial insufficiency, This may also affect the wound healing process, and this may also include altered microcirculation. In the patient with diabetes, the macrophage may well be sluggish in its function. There may be a deficiency of growth factors, cellular senescence in the wound bed. Often there is an abnormal extracellular matrix and there is an impaired quality of the collagen. So when wound healing stalls during the inflammatory phase, there is a persistent low-grade inflammation and an imbalance between the matrix metalloproteinases and their inhibitors. There is a lack of growth factor as these are destroyed by the MMPs. There is also destruction of the extracellular matrix with senescent cells in the wound bed. It's very important when we're looking at wound assessment that we start to think about some of the possible visible factors that would indicate the wound may well be stalled. And this can be seen in the granulation tissue, which appears abnormal. And it might be a darker granulation tissue, too dark, too shiny, too pale. It might be that it's hypergranulating. There might be signs of infection, such as redness, warmth and edema, or there might be the pain associated with infection, which is also a sign of inflammation. The wound surface might have got a slimy appearance that could suggest there is a biofilm present in the wound. There may be slough or fibrin present on the wound, or perhaps a higher than normal level of exudate for that stage of wound repair, which could lead to surrounding maceration. If we look at these two images, the one on the left is a donor site that is 18 months old. The donor site should have healed within 10 to 14 days. Quite clearly this is now a chronic wound or a stalled wound. The granulation tissue is showing signs of hypergranulation. It's quite dark in appearance and the granulation tissue is friable, which can be evidenced by the sign of blood clots on the wound bed. There is also a very high level of exudate from the wound. The image on the right is a chronic wound to the foot, and this has been present for over 3 years. The patient has neurological deficit, immobility and gravitational edema, which has contributed to the reasons why the wound has stalled. When wound healing derails, there are multiple molecular factors involved, and it usually goes back to an unresolved inflammatory phase. As the macrophage is the strategic cell type involved in downregulating the inflammatory response, then this could be the strategic cell to target with a treatment to try and actually move the wound into wound healing. Recently, a new active treatment option has been marketed in Europe which strategically targets the macrophage cell. And in Module 2 we'll be looking at how this works. Hello, I'm Brenda King, Nurse Consultant in Tissue Viability. This is the second part of 2 modules. In Module 1, we considered wound healing and the reasons why wounds stalled, focusing on a molecular level, and identified that the macrophage is the strategic cell in wound repair. In Module 2, we're going to look at a new product, bioactive beta-glucan, which is capable of activating the macrophage cell. There is a potential for a product to actually target the macrophage in stalled wounds. It will restore their functionality and resolve the chronic inflammatory state, and thus restart the healing process. This is using a product that contains beta-glucan. Beta-glucan is a long-chained polysaccharide molecule, which naturally occur as structural components in the cell walls of grain and fungi. Their structure gives them a molecular motif, known as a pathogen-associated molecular pattern, or PAMPs. Our innate immune system recognises these structures or PAMPs as danger signals, and the macrophage will attach themselves to the beta-glucan. There are specialised receptors on the white blood cell. These recognise and bind to the beta-glucans. Receptor binding results in the activation of cells and the subsequent production of signal molecules and growth factors. This allows the macrophage to become more developed into a more mature stage that facilitates the healing process. When the macrophage is activated by the beta-glucans, it improves the effectiveness of the macrophage in its wound cleansing and debridement. Its phagocytosis is improved, and there is improved removal of dead cells and bacteria from the wound bed, including senescent cells. Therefore, it assists in the resolution of wound inflammation. It reduces the number of neutrophils in the wound bed. This allows the right expression of growth factors, supporting cell proliferation, angiogenesis and deposition of extracellular matrix. It promotes wound closure as it releases cytokines which encourage myofibroblasts into the wound, which bring about contraction, and there is improved reepithelialization of the wound surface. By activating the macrophage, which plays a central role in wound healing and orchestrates the wound healing process, this actually promotes wound healing. Woulgan Bioactive Beta-Glucan Gel is a gel with all the hydrogel properties that clinicians are familiar with. It provides a moist wound environment, therefore supporting autolytic debridement. It's soothing and provides pain relief and has a slightly acidic pH. So what makes Woulgan unique is an ancillary component which activates the white blood cell, in particular the macrophage. And it increases the macrophage's phagocytosis and release of important signal molecules and growth factors. Woulgan demonstrated, through a published randomised controlled trial, improved outcomes at a reduced cost, where 2.3 times more patients healed at 8 weeks, with a continued improvement to 12 weeks. On the right in the slide, when compared to the standard of care group, the Woulgan group demonstrates a €740 cost saving per patient. I will now present 2 cases taken from a recent evaluation of 26 patients using Woulgan Bioactive Beta-Glucan Gel, where 7 patients healed. All the patients had had stalled wound for at least 4 weeks, with some many months and even years having had a chronic wound or stalled wound. The first case is a 49-year-old male patient who was a diabetic receiving metformin and also on simvastatin. He had a right forefoot amputation in 2010, and the wound failed to heal after 6 years in duration. He had no evidence of arterial problems, but had neuropathy. The wound was initially dressed with Woulgan 3 times per week and then twice weekly. The wound was considered healed at week 9. The second case study is a 76-year-old female who contracted polio as a child, which affected her right arm and leg and resulted in an altered gait. She also had a history of angina, for which aspirin and statins had been prescribed. While walking her dog, she went over on her ankle and suffered a compound fracture to her tibia and fibula in October 2015. This was surgically fixed with pin and plate, and initially she was treated with reduced compression for a degree of associated venous hypertension. She was referred to the tissue viability nurse in April 2016 as the wound was failing to progress, but had been in this state for a few weeks previously. She was treated with Woulgan, and the wound was considered healed at 6 weeks. In this second and final module, we've looked at Woulgan Bioactive Beta-Glucan Gel. We've been able to demonstrate the results of a randomised controlled trial where improved outcomes at a reduced cost were achieved. And we've also demonstrated in clinical practice with 2 case studies improved outcomes and healing in 2 patients with stalled wounds. As a conclusion to this webinar and to aid reflective practice, based on your clinical experiences in the past 3 months, think of a patient whose wound has stalled and identify 6 patient-related, wound-related and non-wound treatment-related factors that contributed to the wound chronicity. Explain why macrophages promote healing in acute wounds. Explain what happens to macrophages, growth factors, and matrix metalloproteinases in stalled wounds. Describe the wound bed characteristics you would expect to see in a stalled wound. Why is it proposed that a treatment strategy that targets macrophages might help promote healing in stalled wounds? Describe the function of beta-glucan.